Thank you very much. I'd like to thank the sponsors and also the directors of the program for inviting me. I've given this talk a lot, as you can imagine, and basically I've had to change it every week. We're in a little bit of a hiatus now, but we're about to ramp up again. In this talk, and also the talk that Tom and I are going to give a little bit later together, I want to make 2 points. One is that what's going on in the legislation right now has very little to do with healthcare delivery and your practices. Every legislative piece that was a repeal and replace of the Affordable Care Act was really a tax act and not a healthcare act. It was a ramp up for the current tax reduction and tax reformation. So that really isn't going to affect our delivery of care. The second point is that the delivery of care to our patients is going to be massively disrupted, and it's going to be disrupted by an entity outside of medicine and outside of the federal and state governments. It's going to be disrupted by companies like Amazon. All you have to do is look at Amazon's stealth lab called 1492, you can Google it, and understand that they just made a heavy purchase, investment purchase of Grail Technologies. You can Google that as well. That's where the disruption is going to come, and it will disrupt us a lot. How many in here remember walking into a bank to get their money, and then think now, how often do you go to a bank ever? So we talk about a patient-centric delivery of healthcare, and I would say that we could not design a more provider-centric infrastructure of healthcare and reimbursement structure of healthcare than we have right now. And that's ripe for disruption, and I think that's where it's going to come. So the major take-home points here is what's the current status and future of healthcare legislation. We'll go into a little bit of how that affects the demographics of IBD and the impact on our patients. About 5 years ago, I wrote the following in an article called The Road Ahead, that there are 5 strategies that you have to think about, and these are still the same, and they're very familiar to us now. They were really brand new back then. Population management, performance measures, consolidation, which is continuing at an ever-escalating rate, value-based payment, and accountability. So here are the harsh realities of healthcare. And down in the lower left, you can see by the end of Donald Trump's term, 93 cents out of every dollar collected has been pre-committed to either entitlements or debt repayment. And so the major areas of our budget, our $3.8 trillion budget, is basically Social Security and unemployment, health care, mostly Medicare and Medicaid. This is military here, and all the rest of this stuff is going to get squeezed tremendously. So this little sliver of science will continue to get squeezed, and with the current tax plan, the Republican Party has already committed, at least for the current legislation, to have an increase in the deficit of $1.5 trillion over the next 10 years. And you know very well that that's going to come back, and that money will be captured by likely the investment in medicine in some way. So for all the things that you're thinking about, the biggest thing is how do we deal with the price compression that we're going to face. I want to give a little history of healthcare and set a philosophical standard in terms of the legislation, just so we're all on the same page as to where these ideas come from, and also my subtle advocacy for everybody in this room to get much more active in the political arena, because I will tell you that if any of the legislations of repeal and replace had been passed, our IBD patients would have basically been thrown off the cliff. It would have been an unmitigated disaster. And unless we understand some of the reasons behind that, I think we won't be effective advocates. So the Democrats have sought universal coverage for 100 years, but the opposition has really been too strong. So they had to move right, and so they agreed that healthcare delivery in the United States, at least for the moment, is going to continue to flow a lot through private insurers. The GOP has consistently shifted farther and farther right, and I'll show you what that means in a couple of slides. When Obama and his group was writing the Affordable Care Act, they basically gave up on what's called the public option, which is like a federal program for health care. And they moved into the marketplaces. Well, that increased the price, and I can get into that maybe during the discussion, but that increased the price of health care tremendously. And interestingly, Frank Lutz, who was a pollster for the Republican Party, wrote a 2009 memo saying, talk positively about reform while opposing any actual bills. And that was sent around as a strategy to the GOP. So it turns out that they've had 7 years to come up with a beautiful plan. And basically, they pulled in infrastructure that was sort of Obamacare light, which is why Rand Paul didn't vote for it. And really, again, if you look at that, what those bills were really a tax bill and not a different type of health care reform. So politicians campaign as if human life was priceless, but as a legislative body, of course, they put finite prices at the margins of their budget. And Uwe Reinhardt had said, we've routinely ignored 2 moral questions. So the graph on the left shows the cost of wresting another year of life from nature via our healthcare system. So if you start looking at areas down in this part of the graph, you're talking about vaccines and plumbing, basically. And when you start talking about this part of the graph, which goes way high, you're talking about some of the new immunotherapies for rare diseases, where the cost of a single episode of drugs is about 1.5 million all told. So that's what this graph is talking about. And the 2 questions are, is there a maximum price above which society no longer wishes to purchase QALYs from its health system? And the second, biggest one, is should that maximum price be the same for everyone? And we've never really answered that question. So this is a busy slide, and you have it so you can ponder it yourself, but it basically takes, if you are coming from a far-right philosophy, a very conservative philosophy, or a far left, or a moderate left and a middle right, these are the different ways that you look at things like healthcare. Is healthcare a right? If you're a progressive, of course it's a right. If you're a conservative, it becomes much more of a commodity. And one of the basic philosophical differences is, if this is a commodity, then what right do we have to do basically wealth distribution and support a commodity healthcare system? The federal government's role, a conservative would say it should be out of healthcare completely. The far left would say all in. The delivery of healthcare through market. Far left, they're going to be pushing a single payer. Pre-existing conditions, premium support, essential benefit package, Medicaid, Medicare, but all of them agree down here at the bottom that we need to move to a value-based system. So the events leading up to March 10th, we forget, but from 1998 to 2008, our healthcare spending doubled in this country. And in 2009, our economy tanked, but healthcare rose again 4%. And the entire healthcare costs of a family, which are really outlined here, rose on average from $805, this is healthcare spending, not necessarily their cost, to about $1,420. So with that, the Affordable Care Act was passed, and there were 3 foundations. One are mandates, both an individual and employer mandate, and that is now coming up again, and we're not sure, but a retraction of the individual mandate may show up in the current tax bill that will be presented Thursday, I think it is. The second part is regulation. The required benefit set, pre-existing conditions, lifetime caps was taken off. And the third is wealth redistribution via premium support and refundable tax credits. That's really the foundation of the over 2,000 pages of the Affordable Care Act. That's where we're sitting. So who's insured and who's uninsured? And this is a really important slide. Half of us get insurance through our employer, and that's basically not been touched in a critical way by the Affordable Care Act. About 20% is Medicaid, 14% is Medicare, 2% are other things like the VA and Champus, things like that. We remain at about now 8% uninsured, and about 7% are in the small market or individual market. And half of those people that have insurance buy them off the exchanges, and about half on the exchanges. So when we're talking about Obamacare is failing, we're talking about 3.5% of the total insured market. Just keep that in mind. The young adults have benefited most from the Affordable Care Act in coverage, and if you think about a typical IBD patient being a young working adult, probably between 18 and 29 in many cases, the uninsured rate for that group has markedly gone down. And of course, the repeal and replace bills would have absolutely reversed that. Medicaid is really important to understand, and very few people understood it before the current debates. It traditionally was designed for the deserving poor. This dates back to an Elizabethan concept in England of the 1300s. But the Affordable Care Act did what's called socializing Medicaid, and it basically said everybody who has an income under 138% of the federal poverty level should be eligible for Medicaid. And of course, you know that went to the Supreme Court, and now we have a number of states that have expanded, a number of states that didn't. Maine, just Tuesday, was the first state to have a popular vote mandating expansion. It is an entitlement, which means it's a safety net that expands with crises, and the flexibility is linked to the federal budget, which can expand and go into deficit spending as opposed to state budgets. There have been many studies to show that the per-person reduction in medical debt in expansion states, Republican expansion states, has decreased by about $1,000 per person. And it reduced hospital uncompensated care, which is critical for academic medical centers, by $10 billion. So the Regis legislative event, you know very well what happened on November 8th. We woke up a very angry sleeping bear. The Democratic Party was basically thrown out of office at every level of government down to counties. But the other interesting thing was a wall was built, actually, between the conservative and moderate wing of the Republican Party and some of the bills that were tried to go through were really blocked by that kind of division. It's a lot easier to be an opposing party than it is to be a governing party, and we're finding that out. So here's the legislative process. The very first bill that laid the foundation for all of this was actually written by Tom Price when he was in the Senate in 2016. Then Paul Ryan came out with what's called A Better Way, and that was really the foundation for all of these bills. And then it finally passed the House very narrowly, and then marched through the Senate, and as you know, every one of these bills was defeated, including a Graham Cassidy bill, which is the latest. The mantra Obamacare is failing, but the real target was Medicaid, and there was going to be a reduction in Medicaid spending by somewhere between $800 billion to $1 trillion over the ensuing decade. And it's important to understand this. Before the Affordable Care Act, the federal government picked up 50% of Medicaid. After the Affordable Care Act, for a while it picked up 100% and then 90% of that expansion population. And some red states had the largest expansion because they had put in barriers to Medicaid before that. So coming back and then taking that back was really tough for some of the Republican states. This is the fourth attempt since Medicaid started in 1965 that the Republicans had wanted to block grant Medicaid. So this is a very important slide, and it sort of helps us understand what's going on in terms of the economics. This little line, this is 2009 data, but it's the same trend. This little line right here represents, down on the lower left, represents 50% of the population's healthcare costs, not spending, but cost. So about 50% of the population, on average, cost the healthcare system less than $250 in a year. The upper half of that population costs about $8,000. And as you ramp up to a smaller and smaller group of people, the top 1% classified by spending costs on average about $90,000. So what the Republican plan what the Affordable Care Act did was basically decrease the ranges of premiums, and so it spread the costs out, which of course made the people that didn't spend any money angry and wanted to stay out of the market. What the Republican plan said was, let's start by allowing states to waive essential benefits, and there were a lot of iterations of that, and also form high-risk pools. So these people would be segregated, and therefore the premiums would go down for these people. That was before the Affordable Care Act. We had that in 39 states, and they were consistently underfunded, but it really caught a lot of our IBD patients in that pool. And then there are a whole bunch of other things in terms of really relying on HSAs, insurance across state lines, fixed premium support, and eliminating the taxes. But basically, understanding the remarkable difference in healthcare spending for most people compared to the top 1%, 3%, or 10%. So if those plans had gone into place, any one of them, here's what would have happened. By 2026, about 24 million people less would have, 24 million people would have coverage. And a lot of those people would be Medicaid, some employer, and some other. And a lot of that would be young people pre-Medicare, for example. This is an analysis based on the Graham-Cassidy bill, and it basically is the premium surcharges if a state waives the essential benefit mandate. And if you look down to rheumatoid arthritis, which is right here, that's as close as we can come to IBD, it would be estimated that a patient would have to pay a surcharge of about $26,000 on top of their premiums to gain coverage if the essential benefit set was waived. So what now for your practice? So innovators are going to figure out how to care for populations. And in GI, there are really three populations that count when it comes to this. One's cirrhosis, the second is colon cancer, and the third is inflammatory bowel disease. So really figuring out better point of care data input, mostly by the patient, understanding that whatever we do, whether it's a web interface or guidelines or things like that, what we have to do is decrease the transactional costs, and also, most important, have the physicians that take care of patients really not interacting with all of these things in disparate environments, but really interacting in a coordinated electronic health system of some sort. And that's where the disruption of a company like Amazon will come. The other thing is, for most of us, we see one patient after another. And I see a patient who has a positive fit and needs a colonoscopy, and that takes me about 3 minutes out of my 30-minute visit. And the next patient comes in, I'm the fourth gastroenterologist, and 79 pages in PDF format have been placed in Epic that I have to go through and make some sort of coherent conclusion. We have to change our model of care and really do an upfront triage that's much better to take care of different types of patients in different ways. So we're going to thrive if we manage complexity and manage it cheaper, because that's going to be our biggest challenge over the next decade. Create personalized healthcare, and I don't mean by genomic testing or microbiome testing. I mean healthcare that's targeted to the patient's needs, and we spent a full morning understanding that. Reinventing our delivery process, and I would say that we are not going to reinvent it. It's going to be somebody like Amazon or Microsoft or Google. Produce valid quality outcome measures. We also have to align incentives. Our current reimbursement system is not aligned, and Tom and I will get into this a little bit in the second talk. And then finally, create direct links between our best efforts and the value for our patients. So I'll end with this slide saying, in the midst of chaos, there's also opportunity. So I will conclude by again reemphasizing that what's happening in the legislation, we have to pay critical attention to, because if the finances for healthcare go down in a targeted way for patients with chronic diseases and high-risk pools, that's going to be devastating for the patients that we take care of in this room. So wherever your political leanings are, we have to come together to put together a coherent plan forward, or it's going to affect us in ways that I think will be absolutely tragic. Thank you very much.